So without further ado, let's start the conversation off by introducing Dr. Sinead Clark to give our primary care update.
Thank you very much, Andy. So my name's Sinead Clark. I'm a GP in Wrenbury, which is just down in South Cheshire. And I'm also Associate Clinical Director with Andy at Cheshire CCG as well. So I wanted to just start by showing you just a bit of a snapshot of some of the things that we've been doing as GPs and our general practice colleagues over the last few months. So as we know, COVID-19 pandemic started near the beginning of the year, but really started hotting up around April. So we wanted to just show you some of the statistics around what primary care has been doing between April and September this year. You can see that perfectly well for yourselves, but just to show you, we've been open all the way through. We've been doing lots of face-to-face appointments, lots of telephone appointments as well, and some video appointments as well. Carrying on trying to ensure that you get all the prescriptions you need, finding different ways of getting those to you, depending on where you are and what processes we have in our practice. We've still been registering new patients. We've been giving you fit notes if you need them for work. We've been referring you to hospital if you've needed it, and you can see some of the other things on there. So we've definitely been open for business, and we still are. But things are a little different. Anyone who's been in their general practice in the last few months will have definitely realised that. So what I'd like to do is just talk you through a typical Monday. This is actually my Monday from 2 weeks ago. This Monday started, I just want to talk you through what happened to me on that day, and it'll give you a flavour of how things have changed for me as a GP and some of the changes you'll be experiencing if you've been coming in and out of your own surgery. So on a Monday, I tend to get up about 7 o'clock. I have a shower. I'm telling you this for a reason, not because you need to know about all my hygiene needs, but because then I put on my scrubs. And that's not something I did this time last year. I picked a nice dress or top and trousers and put it on, but no. So I put on a very a set of scrubs, which if anyone doesn't know what they are, there's for me, it's a light blue top and trousers. They're made of very, very durable cotton, which enables you to wash them at a very high temperature in the wash. They're also quite hard wearing. A lot of colleagues in hospital wear them. And you'll see by the end of the day why I'm wearing those, I think. So I put my scrubs on. I get myself into work. On that Monday, I was starting work at 8 o'clock. So I put my computer on and I start work at 8 o'clock. But before I enter the building, I sterilise my hands in my car and I put my mask on. I come into the surgery and I take my temperature before I come in properly. So I'm at the entrance and I take my temperature. And that is to ensure that I am not risking anybody in that building. Now, if I had a temperature, I would not carry on. I would get back in my car, I would go home. I would isolate myself until I decided that I need a COVID test, and if I did, I would go and get one, etc., etc. So just like we are, most surgeries are actually checking the temperature of patients on the door. It's not that we don't trust you, but you know, it's to keep everybody absolutely safe. And if you have a temperature on the door, we will talk you through what to do to keep you safe so that you still get the care you need, but it'll be in a different way probably. So my temperature was all right on that Monday morning, thankfully. So I walked into my surgery and got my computer booted up for surgery. Now that morning I had 15 scheduled patients on my morning surgery list. I actually did, I think I did about 11 of those consultations on the telephone. So that's something that's changed hugely for me since COVID has started, and for most of my colleagues, is that we are dealing with a lot more things on the telephone. We are often speaking to someone on the telephone first before we decide if they need to be seen or dealt with in a different way as well. So please bear with us. We are constantly in our heads balancing whether we need to see someone or whether it's actually safer to manage you in a different way without seeing you face to face. And we are trying to keep everybody as safe as possible. And we are also trying to keep ourselves safe, because if any of us get COVID, we're off work for 2 weeks. And we can't serve you, and we don't want to catch COVID and have no symptoms for a few days and spread it by accident either. So there's lots of reasons why it's worth keeping us safe, and it's very much worth keeping you safe. However, we do need to see some people face to face, absolutely. And that morning I needed to see 3 patients face to face. And for that, I put extra protective equipment on. So I don't just have my mask, I actually have a visor, I have a plastic apron, and I have some gloves. So, and then I will come to the door to greet my patient when I know they're here. Some of them wait in the car if they need to wait for me for a while. Some patients can't, obviously. So we can have up to 3 patients in our waiting room. It's quite a small waiting room, very far spaced apart, that can't have any more than that. That presents challenges if there's a lot of people waiting to be seen. And I know some of you might have had an experience of waiting outside your surgery for a while. I can only apologise. We do our best not to have that happen, but sometimes we can't help it. And if we can't see you at the time we've arranged because an emergency's happened, that's the sort of situation where we might have to keep you waiting for a while, but we try not to. So I go and get my patient, we check the temperature before you come in, and then you come into my room and I see you. I also did one of my consultations on video that morning. That patient had a smartphone, so we've got a bit of equipment we can use that allows us to use the smartphone to talk to somebody and maybe to look at a rash or a lump or some issue that they've got. So we have the ability to do that as well. So that was my morning clinic. I had 1 or 2 extra patient phone calls to make. Then I actually had 1 patient that I needed to be seen in our hot hub. So I just want to explain to you what these are. We've got one set up in my part of Cheshire, which is the central bit of Cheshire already, and the 2 other parts of Cheshire in East Cheshire and West Cheshire are currently setting these up as well. And a hot hub is basically just for anyone that I speak to on the phone as a GP. And myself and the patient agree that they need to be seen, but I'm worried they might have symptoms of COVID. So they might have a temperature or a cough or loss of taste or smell. And there are a few other symptoms as well, and things like diarrhea in certain circumstances, for example, that might make us worry. So if I speak to someone on the phone and they're well, and they just have mild symptoms, I might just suggest I keep them at home, but they ring me if they get worse. But if I speak to them and I think, no, that person needs to be seen, because there's a risk they might have COVID, I want them to be seen by someone who has much better protective equipment than me, and who will see them somewhere separate to the rest of my patients, so I can keep the rest of my patients safe, and I can also make sure that person is seen in a safe place for them. So for my patient, our hot hub in our area is run by a group of GPs, so it's still GP led, but we see people in a little building next to the A&E at Leighton Hospital. So I spoke to my patient, I documented what was wrong with them so the person in the hot hub could see what I'd put, and I got them an appointment. So I just wanted to flag that up to you because you might be asked to be seen in a hot hub as well, so this won't be the first time you've heard of it then, if you are. I had a discussion with a paramedic that morning about a patient that the paramedic was worried about but didn't think needed to go into hospital but wanted me to keep an eye on them. So I discussed it with the paramedic, and I also put down in my appointment list to speak to that patient after about an hour to see how they were then feeling, which I did, and they felt a lot better, and I talked to them about what to do if they became unwell again. I had a discussion with our advanced nurse practitioner who'd been to do a visit for me to talk about that patient, and I also had a discussion with the district nurse about a patient who was nearing end of life that our district nurse was managing, to talk about their management as well. I have noted over the last few weeks that a lot of patients are feeling quite anxious about what's happening with COVID and about what's happening with this recent upsurge in cases, and we're having quite a lot of discussions with patients too as to how they're feeling about that and how we can support them. There's also a lot of people who are finding that some of their hospital appointments are delayed a bit longer than they would have expected because of what's been happening around COVID and how it's affected the hospitals. So I'm noticing I'm having more conversations with patients about this, and having to explain to people that for some things we will wait, all of us, if we need hospital appointments, will wait longer for them at the moment, but that the hospitals are reviewing their lists all the time to make sure they prioritise those most in need. I then did some paperwork, so I had prescriptions to do, I had some referrals to write, I had some letters to read from my consultant colleagues in the hospital, and I had some test results to look at, so patients where I'd asked them to have blood tests or other tests such as ECGs and scans. And I actually grabbed my lunch while I was doing that, and most GPs will actually sit and do their lunch while they're doing paperwork, because we often don't get a lot of time to just sit and have our lunch otherwise. I then had a home visit on a patient. My home visit was on a patient in a nursing home. And when I go to do that home visit, again, I drive to where I'm going. I then put on all my protective equipment. I go in and see the patient. I take off most of the protective equipment at the door then of the nursing home, put it in their bin, and then come out to my car. And then I got back to the practice, and we had a very quick team meeting. And the reason I'm mentioning this is because even this has changed with COVID. So normally our team meetings, we all just get in a room and discuss things. At the moment, we're all needing to socially distance from each other as staff as well, as you are needing to socially distance outside our doors as well. So we all sit in our rooms, and we do a bit like we're doing now on a webinar. We all sit and talk to each other on the screen, and have our team meeting separate from each other, and that keeps us all safe, but allows us to keep connected and make sure we manage the patients safely together. I then went into my afternoon surgery. I tend to have slightly less patients planned on my afternoon surgery, but I often get quite a few more extras because things have happened as the day's gone on. So I did my afternoon surgery. I saw 2 patients face-to-face in that surgery, and the rest were telephone consultations. I'd had to do a little bit of extra paperwork at the end of that with some referrals. And then I took my scrubs off while I was in surgery. And I put them in a pillowcase. And I put my normal clothes on before I left the surgery. And what I do when I get home is I put that pillowcase straight into the washing machine. I don't take my scrubs out, because if I do that, I can actually end up contaminating my surroundings and my hands and things with any virus that's on them. I put them straight into the washing machine and wash that at a high temperature, and then I go and have a shower as well. So lots and lots of things, lots and lots of changes in procedures for me. Other things that were running at the same time as I was running my surgery, my nurses are seeing lots and lots of patients face to face. They're doing diabetes checks, asthma checks. They're doing cervical smears for patients. We've run some flu clinics at weekends, but nurses are often doing other flu appointments as well to get everybody vaccinated that we can. My colleague, who's actually a partner at the practice, was in on that day at 7:30, and what she does for the first hour on a Monday is brings in any patients who are highly vulnerable. So they were the patients that were shielding when we were doing shielding during the first wave, and she likes to bring them in if they need to be seen face to face at the beginning of the day, so that they're not mixing with any other patients, and they're coming into the surgery straight after it's had its deep clean overnight, because our cleaners do an excellent job at the end of each day and clean the surgery very, very thoroughly. So she was seeing our vulnerable patients that morning. We also have other people in the surgery who are either phoning people or seeing them as appropriate, including a mental health link worker and a physio first. You'll see people with musculoskeletal problems. So we have a pretty busy team. We were all working really hard to try and keep everybody safe. So that was me with my typical Monday. There were just 1 or 2 other things that I wanted to say before I hand back to Andy. The first thing is there are lots of things you can do to help yourself and to help us. So the first thing you can do, and this is a good thing to do, particularly as winter approaches, because lots of viruses circulate around in winter as well as COVID, as we all know. The minute the children go back to school, everyone starts getting a cold, don't they, and things like that. So this is what we would say is a good minimum to have in your medicine cabinet at home. And you can see it for yourself. When you buy some of these things, you don't need to buy branded ibuprofen or branded paracetamol. If you just get basic ibuprofen or paracetamol, and you can ask the chemist if you're not sure about that, they are really not expensive. And these are all really good things to just have in your cabinet for over the winter, and they will help you to manage some things yourself and then be able to contact the GP if you're still unwell or still concerned. So this would be our minimum that we'd suggest for you to have in, and the total is just under £10. Thanks, Liam. And the last thing I wanted to say to you is there's also lots of other things you can do to help yourself and help your family. We know that all of these things will help you in fighting off any virus this winter. They will help you in decreasing your chance of cancer, heart disease, stroke, and there's lots more conditions. So just by having another go at quitting smoking, most people need a few goes. Don't beat yourself up about the last time it didn't work, just try it again. And you know, anything you can do to lose even a little bit of weight will keep you much healthier and getting as active as you can. And we do know that these three things will help you if you are unlucky enough to get COVID. You are much more likely to cope with it better if you can look after your own health as well. So it's even more important at the moment, but all of these things are good things to be working on anyway. And you can see the website at the bottom, that the NHS website on Better Health, which gives you lots of tips around how to look after your own health, and lots of advice on where you can get support with that as well. Thank you very much. Thanks.
Fabulous. Thanks, Sinead. A day and a Monday, it's kind of similar to my own, to be honest with you. I can understand all the pressures that goes on in the 12-hour days that we're doing at the moment. So thank you very much. And I think you illustrate a good picture of how primary care has needed to adapt within the pandemic as well to actually manage some of the strange world that we're in right now, trying to care for care users and patients. We have some questions. Katie, hopefully Katie, our voice in the sky tonight, is looking out for some questions. So if you do have any questions, please pop them in the chat bar. We do have some questions that have been provided for us in advance of the webinar. So I'm going to ask Sinead to come in. There's one question that I'll start with about PPGs and primary care networks, and there's another one about how practice PPGs, what they can do to support the practice. And I know Sinead's got her views on that one, so I'll let her answer that one. But the first question is, what consideration in the creation of the primary care networks has been given to the networking of the practice participation groups within the primary care network? So in fairness, it's not just us that I think it's such an important question that we've offered that out as well to other people within the CCG and also in our integrated care partnerships. So it's kind of like a consolidated answer, really, because we wanted to make it as full as possible for you. But the CCG and the integrated care partnerships and their organizations, we have two in Cheshire. So we've one on the east side, and it covers the local authority footprints, the one on east and one in west. Certainly the ICPs, they're establishing a system that will include care communities across Cheshire. So it's not just about the primary care networks, which is a general practice thing, if you like, but care communities encompass much more, and it's more of a wholesome community. So they've had representatives from statutory services, but also local people. So we'd welcome input from local people, representatives of our local communities to be involved. So if you haven't had a chance, we'd recommend taking a look. Now, this question came from the west side of the patch. So if you had a look at the Cheshire West Integrated Care Partnership, Making Care Communities Real event on our Cheshire CCG website, and we'll share the link after the chat, actually, after our Cheshire chat tonight, and that'll make it hopefully easier for everybody listening in, because this outlines some of the ambitions for involvement of our community and members of our community. So please have a look at that. The other thing I'd say is there's some patient participation groups that are being part of the start of the development, and they're in conversations already with innovation pilots that are taking place. But we continue to encourage local groups to be involved in the care communities as they continue to grow and develop. So if the links within the Cheshire CCG don't meet your needs, or if there's other areas, it's worth contacting your practice as well. You know, you're the patient participation group, if you like, so the practice could also be able to signpost you to different sites and start working. And I know practices within their primary care networks are working closely together. So the second question, and it's coming your way, Dr. Clark, given the current challenging times that we're all facing, not least in primary care, what would you like to see your practice PPGs do to support your practice?
So I think every practice might have a different answer. Now I know we've got a very active practice PPG. An example would be they've been absolutely invaluable in helping us run our flu clinics the last few weeks. So they're brilliantly important in flu clinics anyway, but this year they have been logistically very stressful for practices to organise, because the last thing we want is for too many people to turn up to their flu jab at the same time. We need to keep everyone socially distanced. We need to keep everybody moving through safely. We've had to make some changes to the way our building works to get people in and out the right way. You know, we were just praying for good weather in case people got stuck outside for a bit. We didn't want, we were lucky actually with ours, but our PPG colleagues were absolutely brilliant. So they explained to people what would happen when they arrived. They made sure they were safe and they were wearing their masks and they understood what was going to happen. They were dotted around the building, making sure people went on the one-way system and knew where to go and was safe as well, because they had to go out the back of our building and round a bit of a bank, and you know, we needed to make sure people were all right. And just the moral support they gave to us and to the patients was absolutely brilliant. So that's just one example of where I don't think we could have run those clinics without them, to be honest. And there are many, many more things that they do. And if I had my practice manager on, she could tell you about all the brilliant work they do. Because we in our village as well, there's lots of things, and there's lots of things they've done during the first COVID outbreak to help keep some of our residents safe and connected as well. So I think it depends on your practice and your area and how much time you've got to give as well, you know, and what you feel comfortable with. But I'm sure every practice is very grateful for support for any of their patients who are happy to volunteer. So I would say approach your practice manager if you're not in a PPG and you want to be, but also if you feel your PPG could be doing more, and speak to your practice, because and you know, and you might have ideas. Tell them what your ideas are, but they might have a whole list of things that they're waiting for someone to ask to help them with, you know. So yeah, just make that contact. We're here as a CCG to support you with that if you need that, but I would suggest that for, you know, that kind of query, I think it's about going directly to your practice and saying, how can I help and how can I get involved? And I suspect there will be loads of ways.
Thanks, Sinead. Thanks very much indeed. And we know the CCG actually has its own engagement and communication strategy. And part of that is how we're placing an emphasis on supporting practices to be involved with their patients and to be using their PPGs to the best effect. So please, as Sinead says, you know, get in touch with the practices and be involved. It's really welcome. So Katie, are there any other questions?
We've had a lot. It's obviously sparked a lot of interest. One question is more of a comment and a question. So it's brilliant the way people are adapting. Do the face-to-face consultation numbers in your slides that you shared, Sinead, do they include the number of video consultations as well?
Right. That is a very good question, because I think those are people who've come into the surgery. But I've got to be honest with you, it's an incredibly good question. I'm cross with myself that I didn't spot it when we were developing this infographic. We will go and find out for sure. I think those are all actually people coming into the surgery. So I will say I think it's that, but like Andy's also indicating, we will go back and find out for sure for you so that we're giving you the totally accurate information. Thanks, Keith.
Thanks, Sinead. So the next, Sinead, thank you for your excellent talk. How are your patients coping with the different type of service? Do they understand the reasons?
Well, I think they do. Obviously, the only way you know that for sure is go and ask all those patients that morning, how did you feel about the way it was handled, you know. But I think they do. Actually, what worries me the most is what happened during the first wave of COVID is that some people didn't come forward who needed to with quite serious symptoms. So I would say that I think if anyone wants to be seen face to face, once I've spoken to someone on the phone and understand why, or, you know, spoken to them in a different way if they have communication difficulties, of course I will see them face to face. And so I hope that they are being seen in a way, dealt with in a way that they're comfortable with. But my big worry is, as we go into higher COVID numbers again, I don't want people to be frightened about coming forward with their symptoms, because the big worry for me in the first wave was that we didn't see as many people as we should have done. And if someone rings me up and they have serious symptoms, I will then arrange to see them and make it as safe as I can. Some people are worried about coming into the surgery, and I would say to you, we have all the protective equipment we need. There are no shortages. Our surgeries are cleaned very, very thoroughly. You can see that if we think someone might have COVID, we've managed them somewhere else, not in our surgery. So we're doing everything we can to make this really safe for you. And if you've got symptoms that you're worried about, please ring us and tell us, because that is my bigger worry, actually, is that people are going to be scared to come forward, especially as we're having this second surge in cases. But I've not had anybody say to me they're not happy, and we haven't had any complaints to our surgery during this COVID period about how people are accessing our appointments. I hope people would come forward and say if it wasn't working for them. I guess that's all I can say. Yeah, is that Andy? Sorry.
I couldn't agree more. So with my practice, we did find it, you know, numbers did drop, certainly March and April. What we're finding now is we know that we have to manage this COVID pandemic, but we've also got to manage everything else, and the serious symptoms are crucial. And so it's got to be as clear as possible that general practice is open. And I am really keen to see patients who have serious symptoms. So please, like Sinead says, don't hesitate. Don't think what you're taking our time. Don't think, you know, you'll be certainly not wasting our time. And if we can reassure you that it's something that's not as serious, then that's fine. That's time well spent, actually. So please come forward. Katie, any other questions?
There are loads, actually. So I think if we reiterate that we will respond to all of them and share all of the questions after the event, I'll fire a couple more your way, if I may. So there's a question, do GPs have a register of autistic people in their surgeries so they can get double appointments and reasonable adjustments in waiting areas if needed?
Right, now we do have registers of people who have learning disabilities. Now, not everybody with autism does, so don't worry that I'm, you know, making that assumption. I know autism is different, and sometimes people with autism have learning difficulties, and lots of people with autism don't. So what we have is a register for people if someone has a learning disability, because they may need all sorts of extra support. Anyone with autism will have that as a what we call a significant active problem on their notes, which means it pops up the minute a clinician goes into their notes. We can see it straight away. We don't have to go delving around to see their diagnoses. So any diagnoses that can have an impact on how someone needs to access our service, or might have a lifelong impact on their care, we put it as a significant coding, if you like, on their notes, so we see it really quickly. So although we don't have a register specifically just of autistic people, we would see if someone has autism quite quickly when we went into their notes. We can also put a little alert on people's notes in our systems, because we're all on something called EMIS, so that if, because there's all sorts of reasons why someone might need a double appointment, or might need some kind of, you know, someone might have claustrophobia and they don't like being inside and they want to wait outside, or that, you know, there can be all sorts of reasons why you might need to manage someone differently. So we can have a pop-up on our screen that comes up straight away. So well, if a receptionist is making an appointment, it would pop up for them and say, this person needs a double appointment, or this person might want to wait in the car until you see them because they get stressed in the waiting room, or whatever it is. So I would say if this is coming from someone who either has someone with autism in their family or a friend or whatever, and they're advising them, I would say ask the surgery if they can put a little pop-up on the screen to say what that person's needs are, because that will make it much more likely that the person actually making that initial appointment will set things up right from the start, basically. Is that okay?
Thanks, Sinead. And one more question, I think, because I'm conscious that we've got Jim to join us as well. There have been a couple of comments and questions around access to appointments. And if I ask one, it's actually from a colleague who works in A&E. Do you think there could be more GPs in GP out of hours services? I work in A&E and I'm increasingly seeing more and more patients coming through to A&E as they can't get appointments.
So is this oh, go on, Andy, you go first, sorry.
Yeah, so is it specifically for out of hours?
So that one's specifically for out of hours, and then we've had a question in terms of the kind of traditional, even in 2020, why do we have an 8:30 a.m. scramble for GP appointments on the telephone?
Two great questions. Right. Certainly with out of hours, it's important to look at the profile. It's important to look at what our demand is, and we need to find system solutions. So I think what will the best way to address this really is to look at system demand and see how we can intuitively find different ways of meeting patient demands. So that's not necessarily having lots more doctor appointments or lots more nurse appointments or advanced nurse appointments. We definitely do need that. And we know, certainly I work as a partner in a practice, and we're trying to recruit doctors is difficult. So we've got a staffing crisis already. So to actually just be looking for more appointments, and certainly within out of hours, we're going to have to think far more intuitively in how we actually manage this. So some of this is managing it with, more health promotion, greater understanding of how to manage illnesses, and we can perhaps do more to actually, it's education, it's training, and actually have the resources to be able to offer patients and direct patients and signpost patients, rather than sometimes the face-to-face. But I admit there will be occasions where we do need to look at the demand and look at the routes and see whether we can actually direct patients to the most appropriate place to see the most appropriate person in the right place within our system. But actually, to answer that specific question, I think Jim's got more a key element to our new system, which the A&E doctor might find very interesting. So I'm going to hold for that one for now. Remind me, Katie, what was the second part?
It was about the systems in place in order to allocate appointments. I think the question is, even in 2020, it seems a little bit archaic that we're having to wait in queues on a telephone to try and get an appointment, and the online system doesn't offer the same sort of level of appointments either.
Yeah, so actually you wouldn't have that wait at 8 o'clock in the morning if your offer met your demand. So there's lots of different ways. We've looked at this in different access models. Pre-COVID, when you look at access and you offer a greater access or lots of telephone, there's, doctor triage, you can triage your appointments. You can see that hump at 8 o'clock actually plateau out. But it's actually, the key is trying to meet your demand. And as demand rises, and you can't meet that with the supply of doctors and nurses within our healthcare system, inevitably there's going to be a greater need. So we have got to look at different modes. We've got to look at things like electronic ways of doing things, e-consult, other agencies to try and support us in looking after, other illnesses and minor illnesses, and keeping healthy and staying healthy, as Dr. Clark was mentioning earlier. So there's different modes that we're trying to adopt and adapt and trying to improve our service, but it's looking at expanding in all of those. That doesn't necessarily have to involve always a face-to-face appointment. you know, that's the the crown of primary care at the moment, and we necessarily need to see some patients, but with the increasing demand, it is a challenge. So I'm not going to say that we've got a perfect service or there is a perfect solution to this. We're always being challenged with this one, and quite rightly, but we're looking for the you know, improved models to try and meet the demand. Would you have anything else to say?
Yeah, I think yeah, no, I agree with that. Obviously, a lot of GPs are retiring. We've got a big problem at the moment across the country, not just in this area, and that's why. And because this is a better model as well, I've always thought this, we're getting a lot of other colleagues joining us in our primary care teams now. So I mentioned we have a physio first practitioner. What that means is a very highly skilled physiotherapist who has extra skills as well around joint injections, prescribing certain drugs and things, and is very knowledgeable and experienced, being able to see people quite quickly if they have what we call musculoskeletal problems, so problems with your muscles or your bones or your back pain or all of those things. We've got a mental health practitioner just starting working with, so you can see people who are having real problems with their mental health, and of course we've seen an increase in this with COVID. So what you'll be seeing at your practices is, because I absolutely agree that scramble first thing in the morning is to do with the supply not meeting the demand. But what you will see is our teams trying to branch out more into a more multidisciplinary team. So it's much more likely that if you've got backache or a problem with your leg, or that you might be asked to see an experienced physio first. And if you've got some mental health issues, you might be asked to see a mental health practitioner. They're just two examples. The GP is still working very much as part of that team, and those members will pass you between the team if they've realised you're not with the right person, but we will work as a team to support you. And that way, hopefully, we will start to deal with some of these issues around the demand. And the other issue that you were talking about out of hours, I worked in the GP out of hours for a very long time. I think what Jim is going to talk to us about very shortly is a very interesting part of the solution around that, around the different alternatives to A&E. And yeah,
let's stop waiting